So today is physical brain week, and next week is going to be emotional brain week. We're going to do the mental health disorders next week, which is going to be a little bit more complex, but that does mean that neurophysiology, our neuroscience background, those prep questions work for 2 weeks. So you get a little bit of the break on the rest of the prep questions. If you look ahead at week 10, you've got like 4 prep questions for skin. So your life is about to get a little bit easier as we go into the end of the quarter. And when I say easier, I just mean in terms of prep work, not necessarily workload, because neuroscience is neuroscience, and that's what this is about. So we're going to start with what happens when you get conked on the head. And there's going to be a lot of potential things that can happen when you get conked on the head. So we'll talk about things like hematomas and herniation syndromes. And it's all kind of talking about the same thing. You get conked on the head. Something happened to your head. And then we'll go into some specific disorders of the brain, like Parkinson's, like physically oriented brain disorders, such as Parkinson's disease, Alzheimer's, dementia, vascular dementia, things like that. And then we're tacking on physiology of pain at the end. There's not too much to that you're covering in here, but I know it has overlap with your other courses. So, like I said, next week we'll do our mental health. We'll talk about schizophrenia and depression and bipolar and et cetera, et cetera. It's an interesting week. It can also be an intense week. And then the week after that, of course, is autopsy visit, followed by skin and burns. And that's how we'll wrap it up. So that was the way that this whole course was structured. It's a little bit top heavy and then lightening up towards the end. That having been said, you know, your week 7, you had 3 exams all at once. Guess what? Finals week, you're going to have 3 exams all at once too, because it's finals week. You've got 5 finals. There you go. And any assignments that are due finals week. So if you want to do well in the final, you start studying now. You're not going to be able to do okay on the final if you wait until the last minute. Any more than you were able to do well on the week 7 exam if you weren't working the entire time. Okay, so let's get into some disorders of brain injury. So there's actually going to be 2 parts to getting conked on the head. First, you get conked on the head. And there's some literal mechanical deformation and literal injury to your cells at that point. So that's the initial insult. What we're going to see is that there's going to be the response of your body to an injury in your brain. Of course, that physiologically is trying to help, just like inflammation is trying to help bring healing things all around your body. But it's going to be especially detrimental in the brain. First of all, because you have a blood-brain barrier, and if that's compromised, blood and inflammation in your brain is a problem. Second of all, we're going to see something called a reperfusion injury when we reintroduce oxygen. This is going to go all the way back to some of the physiology we covered very early in this quarter. When we introduce oxygen back into an anaerobic environment, does anybody remember what that causes? We did cover this already. We've actually already addressed reperfusion injuries in other contexts. Maybe a necrosis can result from this. That's a potential pathway for this. So what we saw it in terms of for reperfusion injury is we have failure of pumps, and we have ions building up on the wrong side of the plasma membrane. We have hydropic swelling. Then you reintroduce oxygen to this ion concentrated place. Then what do you get? It was on a worksheet. I tested you on it. I know. Nope. I taught this to you. Yep, worksheets from this class. Product of built up ions plus oxygen is free radical production. Sound familiar? There you go. All right, so we're going to have anaerobic metabolism leading to, and you know what, as you guys were muddling through all of your answers and coming with up all of that hydropic swelling and inflammatory pathways, those were all related. That's all going to come into play again today. So reminding yourself of those mechanisms was not a bad thing. That was a good thing, right? That's what we're talking about in the brain. It's just going to be extra dangerous in the brain because of that blood-brain barrier. So you're going to start with ischemia. You're going to end with cell hypoxia, mitochondrial failure. You're going to have your mitochondria sequestering calcium. Calcium is going to be in the wrong place due to this failure. You're going to decrease ATP production. You're going to decrease calcium pumping. You're going to have calcium overload within the cell. On reperfusion, you're going to reintroduce oxygen to calcium, and you're going to develop a bunch of free radicals. And that free radical production is going to lead directly to cell death. Also on reperfusion, if you're introducing blood to the brain, despite the blood-brain barrier, you're bringing immune cells, and those immune cells, they're not supposed to be in your brain. They're going to help, they're going to end up lysing your own brain cells. They're going to be the cleanup crew that's going to, those macrophages are going to come along and destroy anything that was half destroyed anyway. Yes?
So is it kind of like when our body releases response, it's trying to help,
yeah.
In the process, it's doing something
absolutely.
bad to our body.
It's trying to help, and in the process, it's going to start destroying our own tissue. Oh yeah, it's a Jar Jar Binks situation. Yeah. With all of the, you know, background nerd hypotheses about Jar Jar Binks included in that. Have you heard the Jar Jar Binks as a Sith plot line? It's pretty great. It actually makes the prequels watchable if you think Jar Jar Binks is a Sith. Okay, so one issue when you get conked on the head is we're going to need to monitor your intracranial pressure. There's not a lot of space in that cranium. That skull is a limited space, and it's very fitted to the shape of your brain, and the only empty, air quotes, spaces are your ventricles. And they're, you know, variable in size, but they're not universal. So if you're going to start inflammation in your brain or any space-occupying lesion, and literally in the brain we call everything a lesion. Everything's a lesion. Cancer's a lesion. A stroke is a lesion, a cut is a lesion, everything's a lesion. I don't know why everything's a lesion, but it is. So whatever lesion you have in your cranium, if it takes up space and starts to push against your brain, it's going to increase intracranial pressure. And here are some things that can increase intracranial pressure, and this could happen fast or slow. So a tumor could grow, and that could be compared to, let's say, a hemorrhage, that's going to be relatively slow, but something like glioblastoma multiforme we know has a fairly quick progression over the span of months before it's lethal. So a tumor would be relatively slow. A hemorrhage would be pretty fast depending on the source of that hemorrhage. Infection would be a span of days, cytotoxic edema, vasogenic edema. We've already talked from a variety of other systems about things that can cause edema in the brain. Anything that causes systemic edema could also cause edema within the brain. And then ischemia and necrosis, such as from a vascular injury, right? Stroke, things like that. A little bit, yeah. So a concussion is going to be a little bit inflammatory, but it's going to be reversible. That's what we say about a concussion. That's part of the definition of it, is that it's reversible. You can also have an increase in cerebrospinal fluid volume, either overproducing CSF or not being able to reabsorb CSF. So do you guys remember synthesis of CSF, circulation of CSF, reabsorption of CSF? Pathways for those? If you don't, you have to review them because that is all significant to you. And then, of course, increased blood volume because that is going to be related. As intracranial pressure increases, as ICP goes up, we say that level of consciousness goes down, LOC goes down. ICP up, LOC down. So it's going to be a very direct measure of intracranial pressure. And we will talk about the numbering system for that. I'm not going to have you learn all of the numbers of the Glasgow Coma Scale, just the ranges. That having been said, you'll probably need to know all of the numbering system for the Glasgow Coma Scale eventually. So when we say level of consciousness, we mean responsiveness, pupil responsiveness, respiratory patterns, response to stimulation. Do you know where you are? Can you respond verbally? Can you sit up? Can you look around? Can you verbalize? Can you open your eyes? Those are things we measure for level of consciousness. So you got conked on your head. Something happened and your intracranial pressure went up. ICP went up. As your intracranial pressure goes up, your brain doesn't have a lot of places to go, but you do have dural venous sinuses and dural septa rather, trying to hold that brain in place. Because you have dural septa covering and invaginated and surrounding your brain and stabilizing it, as ICP increases, you could develop one of many herniation syndromes. So remember what those dural septa are called. You've got falx cerebri, falx cerebelli, tentorium-cerebelli, right? You guys remember those guys? Falx cerebri. So I got my Donovan brain out. Here's falx cerebri, separating the two cerebral hemispheres. Here's falx cerebelli, separating a little portion of the cerebellar lobes. And there's tentorium-cerebelli, separating the cerebellum from the cerebrum. That's where these names are coming from, is these. Does anybody want me to pass these around to remember what's going on with these things? Sure. So when we say subfalcine, we mean subfalx cerebri. We mean that the lesion is probably here in one of the cerebral hemispheres, and it's probably pushing laterally, and it's going to push under the falx cerebri onto the other. We're going to call that a midline shift, where it shifts from one side to the other across that midline. And in our clinical imaging, we're going to see our MRIs and CTs. We want this nice straight line from the back to the front. We're going to see everything deviated across that line instead. Subfalcine. Subfalcine herniation. It looks a little bit like that. I don't know that that's a great visualization for how it's going to look on clinical imaging, but it's fine because there's that falx cerebri. There it is, herniating under it. Yeah. Midline shift. Yep. Tentorial herniation means we're herniating under the tentorium-cerebelli. So we're going from, we're going to shift down underneath that tentorium-cerebelli. And as we move down, there's a pattern to the way this is organized. The way that it's organized is we're going to go sort of top to bottom. We're going to go from less serious to more serious. So we've worked our way down to something that can compress on the midbrain. Does anybody remember what cranial nerves are in the midbrain? Which cranial nerve nuclei are in the midbrain? Hint, they're in order. Midbrain. I'm going to pause again while you find out. Cranial nerves 3 and 4 have nuclei in the brain, in the midbrain of the brainstem. And 3 and 4, does anybody remember what they do? Oculomotor and trochlear, so oculomotor, eye movement. Also something autonomic. Pupil dilation and constriction. So when you have a tentorial herniation, and actually as we move down these, most of them are going to compress the midbrain. So you're going to start seeing blown pupils. Yeah. Yeah. Oh no, there's no pupillary response. Yeah, okay. In order to understand an uncal herniation, you have to know what the uncus is. That would probably help. The uncus, let me get my big brain, because it's colorful and you can see it in the background. So at that basal surface of the temporal lobe, you have this little thing on the temporal lobe that juts out towards that brainstem. That's the uncus. That's your uncus right there. There's an uncus and uncus.
Carry it like it's your baby. You're just
That brain, I was gonna say, that brain is gigantic. I was literally thinking.
So it's actually a type of tentorial herniation. Specifically, the source of that herniation is from the temporal lobe. So again, you're going to start herniating over the anterior portion of the brain stem. And what are you more likely to impact if it's anterior, sensory, or motor? Anterior, sensory, or motor? Motor. Tap the back of your head, move your hand out in front of you, motor. Motor deficits if it's anterior, because that uncus is going to herniate this way. And then tonsillar, once again, you need to know what the tonsils are. And those tonsils are part, actually, no, I was pointing to the wrong part of the tonsils. These are your tonsils. They kind of stick out off of the base of your cerebellum. And those can go straight through that foramen magnum that this is going through. And that's going to be compressing your medullary region, which is where you have what important structures? Cardiac and respiratory control centers are found in your medulla and pons. So once you impact your breathing, that's when things get really serious. So we just went from very serious to extremely serious as we moved our way down this brain. Yeah, if you're going to choose your herniation syndrome, choose your Falcine herniation syndrome. Or just don't get a TBI.
So would these have to do with people who have strokes as well?
Kind of. It depends on the kind of stroke. If it's a hemorrhagic stroke and you have the development of a hematoma, that can be an intracranial hematoma can be a source of increased ICP, which can cause a midline shift.
But these are more like physical traumas to your head.
Yeah. So you could have a hemorrhagic stroke that bleeds into your brain causing a hematoma, and yeah, that would do this. Or you could have a conk on the head, TBI. Yeah, we'll talk about that actually with our differential. With our differential today, the context is a little bit different. I can't like make it a confusing, mysterious differential if a guy comes in with a head injury. He's got a head injury. There's no differential there. But the interesting thing about it is going to be his path to his presentation, his improvements, his worsening, his everything. His little roller coaster of a recovery is quite interesting.
And I feel like it's maybe because two people have the same brain injury and present completely different.
Absolutely.
And feel completely different.
Yep, that is also accurate. Okay, so we're going to, why are people getting up? We're going to talk about a little bit about management. We're going to diagnose probably with a CT or MRI. CT is faster, MRI is better for imaging soft tissue. If you got the time, maybe you would do an MRI. Otherwise, emergency-wise, you'd probably do a CT. And honestly, you can see midline shifts and things like that on CT, so MRI may not be necessary for diagnosing something in an emergency context. Well, we might manage surgically or medically, probably both. We're going to be monitoring ICP and cerebral perfusion pressure the entire time. If it's a space-occupying lesion, maybe we need to remove the lesion, maybe we need to remove the CSF. And then, again, we're going to manage cerebral oxygenation. What we really don't want is ischemia followed by reintroduction of oxygen. We're going to take some steps to maintain oxygenation so that they don't have that reperfusion injury. That's the really dangerous part. So level of consciousness is going to be, we're going to use the Glasgow Coma Scale to measure it. All I'm interested in is mild, moderate, severe. This should be the correct numbers. Let me know if they're not. I think there was a time when it said 12 instead of 13, or it was contradictory. So here's the Glasgow Coma Scale. It's based on eye opening, verbal response, and motor response. So you do a score of 1 to 4 for eye opening, 1 to 5 for verbal response, 1 to 6 for motor response. And then you add those three numbers together. If those three numbers add up to greater than 13, we call that mild. If it's a 9 to 13, we call that a moderate. And if it's less than 8, that's severe coma. The motor response seems to be the most clinically significant, which is why it's on a scale to 6. Questions about that? Okay. Let's talk about decorticate and decerebrate posturing. I actually did not quite teach you enough neuroanatomy to make this 100,000% clear. Basically, what this is saying is that within your motor pathways, you have pathways that control just flexors and pathways that control just extensor muscles. Now, for both of these brain injuries, this is a manifestation of brainstem injury, specifically targeting those flexor or extensor pathways, respectively. They're both very, very serious posturing. The only real takeaway here is that both of these people are dying, and this guy is dying slightly faster.
Can you have a brain injury and still have like flexor muscles that are still out of place without like more injury?
Yeah, you can have a flexor issue. This would be, let's see, make sure I'm saying this the right way. Lack of inhibition of flexor muscles, I think, is the way you would phrase this. Yeah. Yeah, you can have that without it necessarily being decorticate posturing, but yeah. But this is a sign of sudden and extreme brainstem injury, and that's bad. I do have notes on this if you're more interested in it. So specifically, it's going to be decerebrate is the cerebrospinal tract, decorticate is the corticospinal tract or lateral corticospinal tract. And let's see, lateral corticospinal supplies flexor muscles of the lower extremities, whereas cerebrospinal was doing flexor muscles of the upper extremities. And so that's why you have the different postures. It's just slightly different pathways within the brainstem. Any questions about that? It's a weird one, and we kind of gloss over something that's really pretty big. What's that? That's going to be cerebrospinal. And I think I have cerebrospinal, at least part of the cerebrospinal pathway illustrated up here, that red nucleus. Okie dokie. The more manifestations of brain injury, like we said, if you're impinging on that midbrain, you're going to impact cranial nerve 3 and 4. You could also have something along that midline impacting, let's say, the optic chiasm. That's also very closely located to that midbrain, right? That would be something that would impact cranial nerve 2. So pupillary reflex, eye movements, if it's anywhere from 3, 4, or 6, which, how far down is 6 in the brainstem? What level of the brainstem is cranial nerve 6 nucleus in? It's in order. Is it the midbrain pons or medulla oblongata? Pons, yeah, pons. So you can have problems with eye movement all the way down in the pons. Anybody remember what cranial nerve 6 does specifically? It's not facial, 7 is facial. Abducens. Which direction for eye movement? Abduction. It's in the name. Yeah. Doing the cranial nerve face. Just real quick. I mean, you should probably just have that out for this next part. Yeah. Okay. So again, that would be abduction of the eye looking to the side. So all of the other eye movements could be fine, but maybe on just one side they can't abduct their eyes when you have them look over this way. This one looks, this one stays still. And nystagmus is actually usually a result of discoordination between 3, 4, and 6. If anybody wants to see a voluntary nystagmus, I can do one. It's really fun.
Because I just remember from the beginning of the quarter, and I was like, whoa. And you can just make your eyes shake.
I can. It's great.
We would like to see it.
You want to see it? I'll show you on break.
Yeah.
It's almost time for a break anyway. And ocular palsies, so that's going to be brain injury, usually around midbrain pons. Keep in mind these pathways do project to the eyes, so you could have something on that pathway to the eyes that's also inflamed, causing problems with your eyes. It doesn't necessarily have to be brain stem damage to get that. I'll do a couple more, then we'll go on break because it's actually past time. There are a couple of reflexes that can be utilized to monitor brain injuries. The ones on this particular slide have so many contraindications that they're almost useless to you, but I'll talk about them anyway because they're cool. Yeah. So one of them is the doll's eye maneuver. So even if somebody is unconscious, you can turn their head side to side while their eyes are open, and their irises are going to point forward like a creepy doll. Yeah. Which, I mean, if somebody's got a brain injury, are you twisting their neck around? Hopefully not. Let me just see this real quick. Another weird one is if somebody, whether they're conscious or not, you shoot cold water into their ear canal, and their eyes should actually deviate, let's see, towards the cold water as a response. As I understand, with hot water, it actually goes the other way, which is weird. So again, if somebody's like maybe leaking cerebrospinal fluid out their ear, you're probably not going to be doing that. But it's a cool reflex. Hey! Probably really inhumane neuroscientists is how we found out about these, if I had to guess. I mean, a lot of our science comes from like Nazi scientists experimenting in concentration camps and things like that. Not all of it, but there was a lot of neuroscientists before there were ethics boards. A lot of the things we found by like opening up skulls and putting electrodes on people's brains and seeing what happened, that definitely happened a lot too. Okay, I'm going to go ahead. Actually, let's do this one more and then we'll stop. The corneal reflex is when you touch a wisp of hopefully sterile cotton across somebody's cornea, and they should blink. And that actually tests 2 different cranial nerves. It tests 5 because that's trigeminal and it's sensory to the surface of the eye, and it tests facial because that's going to do motor to your face, including blinking. And so, again, where's 5? What level of the brainstem is 5 at? It is still in the pons. It's the mid pons, in fact. And then 7? Lower pons. Yeah. Trick question. It's still the same place. They're really close. Yeah, so that's all pontine. And again, you do have pathways all the way to the face, so you could have something along that pathway that would also cause a problem with that. Okay, I'll stop here and we'll go on break and I'll show